Have when he joins us, if he wants to respond. The second one, have any of the AHC, or mainly the individuals that have dystonia, had as treatment deep brain stimulation? And did it work?
So I can personally say that none of my patients have had deep brain stimulation. We tried to look into that with a couple of patients over the years. But again, deep brain stimulation was rarely used in children at that time. It's only recently been sort of expanded use for other disorders. But I do think that once we understand a bit more about some of the connectivity of the circuits of the brain and HC, the deep brain stimulation might theoretically be of benefit for some of the symptoms, but it would be incredibly challenging and it would have to be focused on a very specific indication. So those are my comments.
Yeah, and I agree, same comment, that haven't had a patient with AHC, though it is being used more and more for children with movement disorders. And there's also a big push, I think it makes a lot of sense, for some forms of epilepsy to be treated with DBS as well. And you'll see more and more expertise being transferred from adult neurology groups to pediatric, and we're doing something like that, for example. But I know of no specific examples in this population, but it's a very reasonable consideration for a non-pharmacological approach in the future. So not quite there, but coming.
I lost Dr.
I
Silver.
don't know,
don't see
Dr.
him.
Silver. I don't know if you want to just try to reconnect. It should pop up to ask you to unmute, but it should be on the bottom left hand of your screen. There should be a mute button, and you just uncheck that.
My guess is it's not Zoom, it's his audio connection in some other way.
Yeah, no, it's not Zoom.
He says can't unmute DBS and RDP unsuccessful.
RDP, why are you?
I have no idea.
Rapid onset, it was tried in a rapid onset dystonia Parkinson patient.
I see.
I don't know the details of that. Maybe he can fill us in, but Kenneth, disconnect and try to reconnect.
Just connect on your local computer. I don't know why he'd be RDP'd into somewhere else. Maybe that's a privacy thing.
And there's a bunch of questions going through the chat too. Is someone going to moderate that?
Sharon is.
You want to answer?
If they're, oh, go ahead.
Okay. Does that, do you want to ask questions? Have me interrupt you, or just keep going with the questions in the list first? Well, let's take one or two of these. Our daughter with AHC, who has ATP1A2, had several episodes of long during deep unconsciousness without epileptic activity, but with serious delayed brain activity. Is this known with more patients?
I think I know what they mean by delayed brain activity. Maybe they could clarify. They mean slow brain activity?
I mean, brains, I wonder if they mean slowing on EEG.
Oh. So yeah. Okay, well, EEG is the gold standard tool for determining epileptic conditions and non. It's a tool, it's not perfect, so there's always so they say very slow activity in the brain. Thank you. There's always limitations in any tool. We definitely have patients.
¿Qué te hemos dicho de eso, Eduardo?
Who have seizures.
¿Qué te hemos dicho de estar pegando?
That don't have good recordings on the EEG because it's very deep in the brain. So there's always that caveat, but most patients you can tell pretty well if they're epileptic seizures or not. And I think what the question is, if it's not that, do you see?
She said very slow activity.
Yeah, thank you. Yeah, associated with loss of consciousness, awareness of some state. And if you are in a altered state like that, your brain waves are slow. So whether, I think again, they're asking about episodes that are not seizures, that of decreased awareness and consciousness. And I don't think that's a common finding I've seen in our patients, but we do see it in general in pediatric neurology occasionally. I'll let the other experts weigh in.
Yeah, I would say the only context in which that has happened in my experience is when someone has had a very bad episode outside the hospital and they get a ton of meds loaded on the way into the hospital. And then it's not uncommon for them to take several hours to get back to normal. And if you put an EEG during that time, you'll often see big slow waves happening. And usually I think it's related to the fact they got a whole boatload of medications to try to rescue what was either an acute dystonic storm of some sort or an epileptic crisis. So that's definitely, we've had a few kids end up in the ICU that way. And in general, when that happens, they can't protect their airways, they're intubated. And then sometimes they get extra meds on top for that too. So those are my thoughts there.
Dr. Silver, I think had a microphone, but now he's muted.
Back, and he's having the same problem.
Well, let's maybe Kevin, can you answer? Courtney asked about a specific medication, one of the epileptic medications, brevitiracetam.
Yeah, I saw. So Briviact or breviracetam is, if you will, the daughter of Keppra levetiracetam. It's not thought to have any special properties, but has the same mechanism of Keppra. And if you ask the drug company, they think it's better than Keppra, but in my view, it's just the same thing, just a different version of it. So there's nothing particular about it. It's a reasonable drug. We don't use it a lot because it's very expensive, and I don't see any benefit to levetiracetam versus Briviact, which is brevitiracetam. And then I don't want to get too much into the weeds, but part of it is drug companies who have brand name only drugs that are new cost a lot more versus generic drugs. And Keppra levetiracetam is now generic and is still our #1 used drug for all sorts of seizures. So again, it's not a bad drug. It's just I don't see there's an advantage to it.
This is just information. We're going to try to go through the list because we had quite a bit of questions from parents, and then we'll do the chat, and the chat will be saved. So if we don't get to all those, the doctors, maybe they could answer those. And
that's fine. I wanted to do one more follow-up because I realized in that one question, Rebecca Vernoff Steenbergen, her daughter had ATP1A2 mutation. And what I will say is that both I have had, and I forgot about this, I have had one patient with ATP1A2 and a pair of siblings with ATP1A3 who had a minor head bump and then went into a sustained coma-like state. This was a number of years ago, actually. With each different, and that has been known. So some kind of trauma that seems to be relatively minor. In the case of the child with the ATP1A3, she was about 3 years old at the time. She fell off the couch, bumped her head. There was nothing to explain it on the brain except for slowing, and she was in a coma for like 2.5 days. So that has been rarely reported with both ATP1A2 mutations in the literature and ATP1A3. And again, it's one of those misunderstood things that what is that sensitivity these patients have to environmental trauma? I mean, you heard Simon talk about the mice and the trauma of moving them, led to massive death. And we know that we protect our patients very much from sudden stress. What is that response to stress, and what are the consequences that can happen in our kids? I do think that is relevant. Research question, but also relevant to how we approach treatments, because if they don't deal with stress, we have to be very careful about making sure we don't put them under undue stress in our clinical trial design, et cetera.
The next question. Does anyone give CBD oil via G-tube? It's kind of a parent question, but in your experience with families.
Yes, all the time. If the
Can I ask
problem is it's so oily, it makes a mess, and then people are not comfortable whether it gets in. So you do the best you can, but it's just it's an oily mess. But it's often used in G-tubes because of the patient population, and as long as you get most of it in, it should be fine. It has a very long half-life, so if you missed a little bit, it shouldn't make that big of a difference.
Do you happen to know a percentage of how much might be getting through? Because I can see it getting oily. Like, do you think just flushing it over and over with water?
Yeah, just do the best you can. And then, as long as whatever you do, as long as you do it consistently, I think that's what you need to know. And then if you're making a dose adjustment, it should proportionally be more or less. It's actually hard to get a level of CBD. There are some companies that sell drug levels for them, labs, but I'm not sure how accurate they are. We're starting to look into that. But again, I think you're worrying maybe a little bit more than you need to. Just do the best you can, and the drug normally gets there pretty well, I think. And I say that because by proxy, if you're on other medications who interact with CBD oil, we can see those levels change pretty easily. So we think it's on board.
I would just comment that I don't think water is particularly good because oils are emulsify it. They don't mix with water. So my recommendation when this has come up is to flush with something with a feed with fat in it, which whatever you're giving through the G tube to feed, flush with that and then with water.
Yeah, that's a great point. It's a fat soluble drug, CBD. Yeah, so you want to use other fats to flush it out.
The next question, if your child has seizures and dystonia or apnea episodes, or all three, how do you know the difference? And do you give rescue meds always or as needed, or just always?
Kevin, you want to go with that first?
I was going to let you, that's really hard sometimes. And the more you do this stuff and the more of an expert you become, the less confident you are, I think, sometimes about what you give the label to this, to that. And we know episodes in AHC can start as dystonia and become hemiplegia. It's this modulation. So I think the practical recommendation I would have is try to have video examples of what you're seeing, show them with your medical providers. You have to agree upon what you're seeing and then when to treat and have an action plan. But if you're a little confused about what to call it, join the group. So I think it's difficult. But again, some patients have very typical events and they replay and they have triggers and it's pretty clear. But again, there's always a little bit of unknown. And again, we use similar medications at times to treat all of them. So practically it may not be as important, but if we can try to separate out them as best as possible, I think that'll also be helpful for future trials as well, where we're trying to target different manifestations. So it kind of depends if you're a lumper or a splitter, but I think you have to be a practical person to decide what they are. But I use a lot of video review, which fortunately is so easy to do now with everyone's technology in their hands. So.
And I agree with that comment, all those comments, 100%. The seizure or the HC action plan, whatever you want to call it, is really important. And especially if you're going to be out, going out of state or whatever, to have something with you in writing or on your phone or something that has a plan so that, the main thing is just you want to rescue it if it's a seizure. You don't want it to go on too long. And I do think seizure-like we can kind of lump together. If they're affecting breathing, that's something I think you need to rescue potentially. But if it's a more typical hemiplegia or dystonia episode, it depends on how much pain they're in and stress it's causing. I mean, so yeah, it does have to be individualized, and it changes. I mean, the seizure quote HC action plan, it really should be revisited at every appointment, just like we do with epilepsy patients, to say, are any new spells happening? What should we be thinking about? What's the downside of not rescuing? What's the downside of rescuing? When would we have given so much medication you have to go to the hospital? All that sort of needs to be worked out, or otherwise you're just going to have to call your team and each time if you're unsure if it's seizure and figure out what to do. That's really not a good model.
The next, how many kids or adults with AHC don't take any daily medication and only use rescue medication as needed?
Ooh, I mean, I think it's very common at the beginning when we're trying to sort out what the babies are doing and before they get their diagnosis. But then it depends a lot on what types of spells. I very few, if any kid I've ever seen over age 2 years who's having, more than a few episodes a month is on nothing. I mean, besides rescue meds, but there are occasional kids that are mild enough and infrequent enough. Actually, the case that I told you about where she did a head bump and went into a coma, that was one of those cases where she had relatively infrequent episodes. So we didn't have her on anything but rescue, but then she did that, which we still don't know what that was. So, I think that's my answer. Kevin, do you have any thoughts?
Yeah, I think most of my patients are taking something, but you could also rewrite the question, and I'm sure we'll talk about some I will rewrite now is, what's the efficacy of flunarizine? So it's either on flunarizine or you're not for daily medicine. So I think it comes down to that. Otherwise, most of our tools are rescue type medications.
Yeah.
So.
You mean in the ones that don't have proven epilepsy?
Well, I'm talking non-epilepsy, man.
Yeah, non-epilepsy.
Yeah. If you have epilepsy, then
Yeah.
all the patients I see at least are going to be on something to prevent those episodes. Yeah.
Is trileptal considered a no-no for ESES or CSWS? And it has been known to worsen it or induce that type of epilepsy.
Yeah, so it gets into what type of seizures people have. Some medicines are better for other types. Some medicines make some type of seizures worse. And just as a generalization, the ESES, which is electrical status epilepticus of sleep, and the CW is continuous wave spike during sleep. So there's various sleep manifestations that are fairly well known in epilepsy. And those are examples of what we call generalized forms of seizures where the whole brain is involved. And trileptal, also known as oxcarbazepine, is really only good for focal seizures. So if patients had those conditions that were asked about, I would not put them on a medicine that's only good for focal seizures. So as a general answer, no, don't use that one. And sometimes it does make it worse. But again, I don't know the details, but that's a reasonable high level view of it. And other medicines that are out there are good for generalized seizures and focal seizures. So we tend to use those more too, for that reason.
Is there an ATP supplement that could be given?
Yes and no.
Yeah.
I'm joking.
Not well studied.
There are certainly supplements, but yes, I don't think I don't think it's going to hurt anything, but I don't think it's going to help. Again, we don't have a lot of data, so I would like to see someone study that further, but I'm not impressed by what's out there to think that it's ATP.
Metformin has been used to treat cerebral palsy and other medical complications besides diabetes. Has it been used on any of the AHC kids to reduce symptoms or improve overall cognitive and physical function?
Not to my knowledge, there hasn't been a trial. Whether any individual child anywhere or adult has been on it. Metformin, can be used to treat metabolic syndrome in diabetes, and a lot of our young adult patients develop, excessive weight gain as they're not as active as they should be. And so it's certainly possible that would come up as a treatment for either polycystic ovarian disease or a pre-diabetic syndrome. And my concern would be, they already have, we don't have any experience. We don't know how they would react. So I would, if that does happen, I would much prefer to see that done in a clinical trial setting.
Midazolam Versed is a nose spray, I guess if used. How many milligram dose your kids get for an episode's cramps, dystonia, and how often could it be given, once or twice a day?
Kevin, I don't know what.
Kenneth
That's
Silver.
very specific. Oh,
Yeah.
Kevin.
Joined the meeting.
I think they're talking about AHC symptoms, obviously not seizures.
So using nasal Versed, it sounds like.
Mm-hmm.
Yeah, I mean, so it's a benzodiazepine. So I think it's a nice addition to the tools we have to deliver drugs like Valium, clonazepam, all those things. This is Versed. And we use it a lot for rescue for seizures. So if you're giving some benzodiazepine for an AHC episode, whether it's epileptic or non-epileptic type, it makes complete sense. I think it'd be fine. It's easy to give. It's a reasonable route, but I wasn't sure what there's more specifics to that question than that.
And it's Kathy, I would say that my experience in using it for an HC episode, like if it's a full body dystonic episode, I think it makes sense. But it can burn when you spray it in, and it can be really noxious and it can make them more upset and agitated sometimes when you do it for HC episodes. So I've tried not to use that. I've tried to find alternatives to nasal Versed if it's not an epileptic-like episode or a whole body dystonic crisis. That would be my bias. Obviously, in the older kids, it's harder. You can't give rectal Valium very easily if you've got, a 180-pound person. And there's only certain ways you can get these rapid-acting meds to work. So it's a great tool in that setting. But it is a little bit uncomfortable.
Yeah. And there's rapid dissolvable oral versions of these medicines too, which is probably the third option. Just as long as you can tuck something in people's mouth, it'll get dissolved pretty easily. I also think insurance will probably not pay for nasal Versed. Nasalam is the trade name. You can do like a homemade version, but if you do the typical product, they're pretty expensive. And then usually it's only for an epilepsy. And even then, we have to fight insurance to get that covered. So it becomes a practical question again about what you're trying to do and what forms. But yeah, usually we're trying not to use the rectal diastap because people don't want to blame them. So it's at least it's an option. It's reasonable, I think.
Hi,
I'm
this is
gonna
Kenneth
I'm
Silver.
gonna ask
I
a
don't know.
follow-up.
Hey, Ken's on.
Oh,
Great.
yay.
Go over, Ken.
Could you
I
hear
wanted
me
to ask a
okay?
follow-up on that.
Yes, we can. We can hear you.
Okay, I can't do screen and audio at the same time.
Oh,
I don't know what's going on. But yeah, so I think, there's certainly the advantage to the nasal midazolam for kids who have real severe quadriplegic attacks, which last for prolonged periods, or dystonia, which is very painful and prolonged. I think I would use it with the same kind of limitations and indications for a seizure, because these can be quite disabling and devastating attacks. I think for, a mild attack that's self-resolving in a short period of time, I would not overuse it. I mean, they recommend certain limits about how many doses you can give over a period of time for both diastat and midazolam for seizure indications. I think I would use the same criteria for AHC, plegic or dystonic attacks.
Okay. Has anyone tried gabapentin and how it works for AHC kids, since it increases GABA B, and we know that our kids have GABA B deficiency?
So I have been trying, I've used it sometimes in patients who have painful dystonia to see if it's helpful, trying it both acutely and chronically. And sometimes it does seem to help, but I again, without a trial with a specific indication, I'm not sure. I mean, it's one of those things that's in our toolbox, and it seems to help some patients, but every patient's different that you try. And so I find it's something that I use when they're going through if they're one of those kids that cycle through and will do days in a row of terrible, painful dystonia. sometimes I've been trying to do it for that period of time to see as an adjunct. But I don't know, Kenneth or Kevin, if you have any comments.
Yeah, I would agree. I think, you know, for pain relief, I think gabapentin is useful in sort of neuropathic type pain, muscular spasms. I don't know, some people use it for spasticity, dystonia, seems to help to some degree. So I think it's a reasonable thing to try, at least on a few attacks. And it might or might not help. I think it's trial and error.
Yeah, and we use it specifically sometimes as a sleep agent as well. So it can just help people go to sleep and get better in that way as well. And then I'd also push back a little bit, even though it sounds like it has something to do with gabapentin. Really, we don't think it has anything to do with GABA. It's more in the calcium signaling pathway. So I think the name is misleading when it first came out.
Prolonged spells of not breathing in AHC. What percentage of patients with AHC does it affect? And do you have any idea about the cause? And then I have two other parts of it.
So, as Dr. Swoboda remembers, our publication from 2009, Dr. Sweeney was the senior author. Apnea was reported in about 20+% of the patients, some as young as newborns, where the first manifestations was neonatal apnea. And then so later on, it became evident that they were having alternating hemiplegia of childhood as their underlying etiology of these apneic spells, and you know, obviously initially diagnosed with seizures, epilepsy, but you know, it was identified secondary to the syndrome. So I think these are common. We would see it in older children during a bad attack, a quadriplegic attack. They might have some hypoventilation. What is my theory without testing it? I think it goes to the brain stem. That's what controls breathing. I think that ATP1A3, what first thing it might be the brain stem generators to drive breathing, could be affected with the disease. Could be the other centers where the alternating hemiplegia start in the cortical neurons, and then because of spreading depression process, it goes down into the brainstem. So they start with hemiplegia, then as it progresses throughout the brain by spreading depression, it involves both hemispheres and or goes down, spreading into the brainstem. And it's shown certainly that you can get spreading depression going into the brainstem. So I think these are the mechanisms of the apnea that we see as an integral part of the ATP1A3 mutation in AHC. That's my opinion.
Yeah, and I'm going to add to that to say I think it's really under-recognized. I started a number of years ago recommending that all newly diagnosed kids get monitoring for their oxygen sat and pulse, so that we could try to find those kids and follow what they were doing with their prolonged spells. And this led us to discover that that sometimes when we would, during prolonged spells or during a particularly bad day, we would see periods of time when these kids were awake that they would go and desaturate, even if it wasn't clear that they were in distress or having, you know, it wasn't so obvious, not like they turned obviously blue. And sometimes it occurred when they were trying to eat. Unfortunately, medical companies and insurance don't often allow you to keep those monitoring machines. So I often tell parents to get to buy their own pulse ox to be able to monitor kids during spells. But in addition to the brainstem involvement, which I agree with Kenneth that it's a big part of HC, You see that when they get the dilation of their eyes and the autonomic symptoms as well. You also can have kids that have, I think, tightness of their chest muscles, where they get, they can't take a deep breath. And it causes a great deal of anxiety, and they can also desaturate with those kind of spells. So there are some unusual types of spells, and I think it's important for us to know what's happening. And then the third time when that I think we have to think about apnea is not to forget sleep apnea. Many of our kids don't get proper sleep studies, but when we were doing the trial of sodium oxybate, one of the reasons we couldn't go forward safely with that drug, even though we were trying to use it just during rescue during the day, is we found that when they went to sleep that evening, if they had gotten even a small dose of sodium oxybate during the day, they had sleep apnea at night. So this kind of gets us to a very important topic of, what's happening during sleep in our kids, and how restorative is sleep really? Are they getting into normal deep sleep? There's just so many unanswered questions, but the ability of kids to go through a sleep study without getting completely agitated and stressed out has been really challenging. And also to get insurance to cover it has been challenging. So lots of different complex answers to that, but I didn't want to fail to mention that because I think it's an important clinical issue that is underrepresented right now.
Just to follow up, and another question with that is, what is the correct terminology? Prolonged apneas or respiratory arrest?
I mean, I don't know. Go. Someone else can take that one. I mean, prolonged apnea, once you get to a certain point, it's respiratory arrest, right? Like that's somewhat arbitrary, because you can have a normal, you could have apnea where they aren't breathing for 20 seconds, but then they might resume breathing again. And that would be
and also,
yeah.
Yeah, and also I think there's a degree. So it looks like the observer, the parent, that they're not breathing at all, but sometimes they have very little chest movement, and they're managing to have some shallow breaths or a hypopnea, which is not so evident to our eyes. They don't develop the typical cyanosis of the lips, and so I think they're getting some area, and there must be some breathing. You have to monitor them actually during an attack and measure their oxygen sats and their chest wall movements, which might not be so easy with a not in a controlled laboratory setting. You might not appreciate how much breathing you're really doing.
Is flunarizine beneficial to AHC patients? And is it likely to be causing some of the developmental problems many of us are seeing?
Should I set off that tone? I mean,
yeah, sure. I saw you come up.
Most of you who know me know I am, from the very beginning, I'm a strong proponent of flunarizine. We don't have as good controlled, blinded studies as we should have, especially after so many decades of using this drug. And I think it was, the rarity of the condition and, the difficulty with getting funding for controlled studies. But right now, that's, I think, still the best drug that we have. And it's the disease which causes the developmental delays. This was seen even before physicians started treating patients with flunarizine, that one of the hallmarks of this syndrome is that children do have developmental delays and cognitive deficits and persistent motor deficits. And this occurs irrespective of whether or not flunarizine or not on flunarizine. So it would be inappropriate to blame the flunarizine on the deterioration we see with our children. And in fact, there is some suggestion that patients actually get worse if they were on flunarizine and this flunarizine has stopped. So I think the flunarizine has and will continue to play an important role in managing these patients.
And I'll just add to that by saying flunarizine is a drug in serious need of a tune-up, with more studies about dosing, a way to measure the potential impact. And, you know, I have no doubt in my mind that it helps some patients. I don't know if it ever causes harm by interacting at some point at some dose or with other medications or things like that in some individuals. I certainly don't think it's good to suddenly stop it, even if it has a long half-life. And I think that holds true for many, many medications. But I still find it extremely frustrating that we know so little about this medicine and how to dose it properly.
I think, and again, from Dr. Sweeney's paper with both Dr. Swoboda and I were co-authors, that it was looking at over 100 families how they rated the efficacy of flunarizine and potential side effects. And about 60% of the families said, yes, it did help their children. I mean, this is parents' subjective findings. And only about 2% was there any adverse effect. And I could tell from my personal experience with this medication, I think only less than a handful of patients have really ever had to stop the flunarizine because of the side effect.
I'll just add to the barking dog that I prescribe flunarizine. I'm a proponent of it. The data would never be approved by the FDA for an indication at this point. So that's how flimsy it is. And then I've been approached by a pharmaceutical company in the last year who actually were planning to do a US trial, I think pre-COVID, to really address this and get some good data. I don't know what happened with it, but that I would hope would happen at some point. So we can at least, again, as Dr. Swoboda said, have some efficacy measurements, have some consistent dosing, have some objective side effect, placebo kind of information. That would be very helpful. And then on the scientific level, it's hard to know what flunarizine is doing. I can't connect the dots easily between this drug and the sodium potassium ATPase. You can see there's some mouse models where you can show evidence, but again, there's very little, I think, human clinical data that supports its use. But we use it, and I think it's reasonable. But at least if we knew how it worked, maybe we could tweak it and have a better molecule that works even better. But you know, we just have. It's a little bit embarrassing we don't have the basics here yet, because it's just
so if I could stick my neck out with biochemistry, even before we knew about the ATP183 gene mutation, the early monographs of the drug, they reported that flunarizine decreased firing rates in where there was increased extracellular potassium. I think that's the connection.
Yeah, I don't think we know, but I think there's something. And I think if we understood better again, then we can be much further along to the next flunarizine, which is what the field needs, is a very tuned drug that hopefully hits the actual mechanism. But anyway, I think it's coming. But if anyone knows else in the panel about any pharmaceuticals who want to do clinical trials from the board, that would be tremendous. And I know there's interest, but I don't know what the reality is of where they're at with it.
So I can just give you some brief follow-up. Xenon Pharmaceuticals
Yeah,
was
that was the
interested,
one.
and
Yeah.
that's the one that talked to you and I and others.
Yeah, that's right.
originally.
That was a while ago, at least for me.
Basically, what they decided to do, because of the rigor with which the FDA wanted them to do controlled trials, is they decided to go back and do trials, a trial with absence epilepsy, because there's some data that it could be an effective adjunct medication for absence epilepsy. So that's the study that they're doing now. And apparently it's all open label again. So it's going to be a little tricky, but it has shown it's met their mark of 50% reduction in seizure burden, supposedly. Now, I haven't seen this data. I will say that that might explain why it shows in our recent survey that we did, because I believe parents have some perspective on this. I do. And I know Kenneth knows this data better than anybody in terms of because he was involved in the initial study, which really was a very carefully thought out study, even though the data was lost in the end, et cetera, that in terms of it getting supported to the FDA. But if it helps in the E815K, perhaps it's having something to do with epilepsy as opposed to the other types of spells. I don't know. Not sure, but I think it will come back. I just don't know that they're ever going to do a trial. I think the indication for further study in the US for FDA approval may well be absence epilepsy.
Yeah, but if they have that, at least we'll have dosing information,
Exactly.
side effects, and then if it becomes, people should know if a drug is FDA approved for something,
Yes.
and all of a sudden we can use it for anything within reason. So it is a big step, but yeah, I understand their decision.
Yeah, although I'll be cautious in that if it is FDA approved, the cost of like $30, $50 a month from Canada now will probably be thousands.
Yeah, exactly. We've
From
seen
the
that
United
before
States.
with other seizure drugs. They were kind of a pain to buy over out of pocket from Canada, meaning hundreds of dollars, maybe per month, max to thousands of dollars. And if you don't like it, it's because the US healthcare system is what it is. But yeah, we could expect, but at least insurance will often pay for it at that point if it's FDA approved, but it'll not necessarily become easily available and might cost some people more out of pocket to get it that way. Yeah, but again, I think it's progress, so I'll take it. But there's some things to worry about when you ever get FDA approval, because it becomes usually, again.
My worry is that what's gonna happen is what happened with cannabidiol, which is it'll get approved for absence epilepsy, but then absence epilepsy per se, if it is made in an HC patient, it's part of a different disorder, and they won't get approval to pay for this expensive drug, and then we will be in even a worse crisis situation unless the company agrees to provide it on the compassionate use basis or something.
Yeah, no, then
It's going to be a mess potentially.
Yeah.
If we don't.
Then it becomes an insurance issue about whether they will pay for an FDA approved drug or not. So it's terrible.
Next question. Do you see an increase in seizure activity in AHC patients as they get older?
I would say that the rate of confirmed diagnosis of epilepsy goes up, but exactly when seizure activity starts in those that ultimately become epileptic is not quite as clear. And in Matt's paper, Dr. Sweeney's paper that Ken was referring to, there was quite a delay in a diagnosis of epilepsy. And I find that's true for many of our patients who have for a long time, sometimes seizure-like episodes that are relatively infrequent or brief. And it takes a long time before anyone's convinced that they're seizures. And sometimes that leads to not good treatment of patients who probably had epilepsy for longer than we realized. That's a concern I have.
My impression is that seizures do sometimes start anew until around puberty. And then seizures seem to be less of a problem, and clinically we face more difficulties with dystonia taking over as the main paroxysmal symptom.
Is clonazepam known to cause behavior problems? What about clobazam? I'm not going to say it. I said the first one, now I can't say the second.
Clobazam.
Clobazam.
Yeah, clobazam, which is Onfi.
Thank you.
So those are all benzodiazepines. In general, they're pretty well tolerated, but they are drugs that at high doses sedate you and make you sleepy, and at intermediate lower doses can disinhibit you. So if that's what they're getting at, some people have worse behavior because they're a little disinhibited. I hate to use the analogy, but it is like having one drink and you're like, oh, hey. And then you have 4 drinks and you're sleeping. But it's really a very similar approach. So yeah, I think in that sense, behavioral disinhibition is definitely part of it. But overall, I think they're pretty helpful drugs that don't typically hear behavioral things with it, is my impression. Let's see what other people think.
I agree with that, Kevin.
I suspect that question is coming from one of my patients, so I won't comment any further.
Can anxiety and/or excitement trigger a seizure? Suggestions on how to manage. And I think they're talking about true, seizure, not seizure-like AHC.
Generally, no. I mean, everyone's different, but excitement usually is not a trigger for an epileptic seizure. It can happen, certainly, but it's not, I think, a common scenario. I'm much more inclined to think of it as for the non-epileptic manifestations, but you thought this is more of an epilepsy question.
I mean, I've seen the anxiety or excitement much more commonly lead to whole body dystonia.
Yeah, exactly.
That becomes a crisis. Now, again, whether, some of those patients, what the mechanism of their whole body dystonia is when it gets really severe, that's another question, but that's a very frequent thing that happens when the older patients come to clinic. If they have some history of dystonia and they get, anxious or excited or stressed, that's a common problem. Is the worsening of dystonia, but not necessarily altering their seizure threshold per se.
I think there's an old published study on behavioral effects affecting seizures in epileptic patients. I can't remember who the author was. It's quite an old paper, and he really elucidated all kinds of emotional stresses that people have that can trigger an epileptic attack. And it's amazing that we don't pay enough attention to these emotional triggers, because everybody has emotional triggers for something, but it seems that these are clearly trigger factors for seizures. I think probably as epileptologists over the years and have downplayed it because we don't want to overprotect the children. I mean, if you're worried about every little thing causing a stressful situation, then you're going to create great stress just trying to protect them from every environmental stimulus.
Yeah, no, I agree with that. My perspective is when we hear these kind of things of triggers and we bring people to our hospital with EEG and video monitoring for a few days, we reproduce the situation that they're talking about, including within reason, stress and anxiety, and almost always it's not epileptic what's triggered. So I think, again, it can happen, but I don't think it's a common association, and it's much more likely, a loud sound or some sort of frightened, that can throw people into some types of seizures, but just anxiety itself or emotional. I mean, it's hard to find, but again, when we do that exercise, the yield of something being epileptic is pretty low, and we're trying again to exactly reproduce what they're doing at home. So, but I think you're right.
I think
There's more out there than we know. But.
Yeah, I think from a pathophysiologic perspective, it depends on what they do with anxiety, because you can hyperventilate with anxiety, or you can do different things with your breathing that could theoretically alter your pathophysiology and it change your threshold for having a seizure. I suppose that'd be something interesting to look at.
This may need more information from, if someone's listening to ask this. Is it a seizure, AHC, or combo? And I'm not sure if it's a newly diagnosed child that the parents aren't sure what is what now.
Did it come with videos or something?
No, but I do get a lot of these questions when we get a newly diagnosed child. The parents are like, well, what were we seeing before the diagnosis? We thought were seizures. Is it AHC? Is it seizure?
So I can address that. I had a couple patients recently who came to me for this type of evaluation. They have a diagnosis of AHC with different episodes. They have epilepsy or not, and it's hard to know from the history, and the family's unsure too. So we do the same thing we usually do, is we admit them to the hospital for several days to get the best possible test for seizures, which is EEG during an episode. And by doing that, we can hopefully identify, and by comparing videos and talking about what we're actually seeing to what the family is seeing, a good accounting of what is epileptic, what is not, what do they look like, how distinguish them. So you start to build that story for each patient about what's going on. And we've done that. We found some patients, are actually not having epileptic seizures or having other ones, and some patients have combo, and it's all possible. So when I hear the story, I think it's really hard to figure out just by history what's going on. Even by video can be misleading. So I almost always go to the gold standard, which is capture events on video with the EEG running, and then you can more confidently move forward. But again, it's hard because many people are misdiagnosed with epilepsy when they first present, as I think everyone, as Paul knows, but then you also have it later, and then it can be different things. So yeah, it's so confusing. I think you just need good data for each patient. So I have a very low threshold for admitting these patients to the hospital to really figure out best what's going on. And it usually is very helpful, I think.
If a child is declining significantly, cognitively and physically, is there anything that is shown to help?
That is such a hard question to answer, because are you talking about a sudden observation or a gradual? A sudden observation would make me really want to work them up for, get laboratory tests. Could there be some secondary factor contributing? Are there undiagnosed seizures that are occurring that we're not aware of? If you're talking about a rather sudden decline. Most of our AHC patients have periods where they're quite stable and they're learning, but then they'll go through a period of really bad episodes, and then they might lose some of those abilities and then regain them again. What happened during that? Why did they forget how to do things that they previously could do, or why did they suddenly have to relearn some skills? I don't think we understand exactly what's happening, but I think the brain is under substantial stress when there are a lot of episodes happening, and it's not working normally to consolidate memories and make all of the progress that it can, I think. But we don't understand that mechanism yet.
Yeah, a lot of the question is, when we see patients in child neurology, do they have what we call a progressive encephalopathy? Meaning, is it a condition which will make them worse over time, or is it static, meaning that whatever the brain changes are, patients will remain relatively stable? I'm not sure where to put alternating hemiplegia of childhood. Maybe my co-speakers can offer that. The Europeans looked at their patients, I think, over several decades, and their conclusion was this is not a progressive disease. Patients remain stable over decades as far as their functioning. But as clinicians, we certainly see patients who have a bad attack, and then it takes them longer to recover after the attack, and sometimes they do not recover back to their baseline. Also, with non-paroxysmal events, we see maybe some worsening ataxia or worsening movement disorders over time. So I think there are some progressive symptoms over time, and certainly with bad attacks, you can have a progressive loss of function. So as Dr. Swoboda and others suggested, it would be important to know in this particular case what the circumstances were. So as far as treatment, preventing this is obviously to prevent a bad attack from happening. And we discussed, approaches to manage those kind of bad attacks.
To just add to that conversation, one of the challenges about determining whether a disorder is progressive in childhood is that all of the rapid developmental changes that are happening during childhood. And there are a number of disorders like this one where they seem to be developing completely normally between attacks at the beginning sometimes. And then gradually they fall further and further behind as their peers make progressive gains. And I do think that there can be some degeneration that's happening that's masked by the capacity of the brain to develop at the same time. And I think that we were talking a little bit, talking about neuroimaging abnormalities in the animal models versus the patients. We do have some autopsy data. We do have some data that suggests that, yes, there are those patients who clearly have changes in signal abnormality and volume in the brain, but there's very selective vulnerability of specific cells like the Purkinje cells in the cerebellum, where you can have, in a young adult who died, for instance, a normal size of most of the cerebellum, but yet very few Purkinje cells are left that are functional. And I think with many neurologic diseases, we don't understand that selective vulnerability, but I think that's what we're talking about in HC. And I still think we don't know when they have a bad series of episodes, or particularly when they have an episode of status epilepticus when they're young, what cell loss is actually happening. There could be cell death occurring in selective brain regions that then change things. And I think the hint of that we have is this sister disorder of rapid onset dystonia Parkinsonism, where you had people that, at the first reported recognition of this disease, people who were relatively normal, developing individuals who went through school and didn't have any known neurologic disorder, and then went through an incredibly stressful experience like boot camp, and then developed over 3 or 4 weeks a progressive dystonia. What actually, that's the same gene. And so I think our tools are insensitive. I think that we need better tools and modalities to understand pathophysiologically what's happening. And I just have to say, not being an epileptologist, but having trained at an institution where we did a lot of depth electrode recording, when I was at the Beth Israel, seeing the adult unit, the epilepsy unit, when I was training 25 years ago, we put depth electrodes in all the time to record events that no one ever picked up as epileptic on surface recording techniques. And I feel that those are often what's happening in the epilepsies associated with AHC patients. I feel like if we had depth electrode recordings, that we would more easily be able to distinguish, because I think that there are more epileptic events than we fully understand as time goes on. And I think it's related to degenerative loss of cells in circuits. That's my belief, just based on just all of the data that I've seen over the years, looking at brains, looking at images, looking at different patterns of abnormalities on the images, looking at exams of patients, et cetera, I think that there is damage. I think it is progressive, and it's masked to some degree, unless there's a very significant stress or illness. And then you see this decremental event occur, and they transition to permanent dystonia where they didn't have it before. Or they have a really bad series of spells and they weren't ataxic before, and then all of a sudden between 1.5 and 2, wow, they really look ataxic. That's my feeling about what's happening.
Are there other AHC kids or adults that have hallucination or delusion after having many seizures or after waking up from a medically induced coma due to having so many uncontrollable seizures?
Yeah, I think we see in kids who come out of the intensive care unit after prolonged seizures, prolonged sedation, medications used to sedate them, and a medically induced coma. I mean, we do see this psychosis, shall we call it, after recovery and withdrawal of these medications. I don't think it's specific to AHC, but it's a known phenomena.
How many AHC kids, adults have a VNS implantation? Does it help for seizures and or AHC dystonic episodes?
I'm only personally aware of one patient that had one many years ago, and it really seemed to help reduce his episodes of hemiplegic attacks. I'm not aware. I'm hoping Dr. S, maybe he has some more recent experience. It's very hard to get a VNS for anything but refractory epilepsy, because again, it's an expensive therapy and procedure. So Kevin,
Yeah. I don't have any patients with AHC who have a VNS, but I'll just say that the VNS is okay. It's a non-medical approach for seizures and has been used for patients with depression too. No one ever says the data is great other than the company. I like to think of it as a first pass attempt to have, sort of neurostimulation devices, but it's pretty dumb, crude event, and there's much better things out there that will be used more and more. So I don't think there's a bad part of it, other than it's a surgery and it's expensive, but I don't think it's great even for epilepsy. But we use it for some patients just to lower the medication burden, but I don't know of any AHC patients in particular that have been used in our group. So.
Yeah, I think in the literature, there's some who say, well, it really helped my patient, but usually, negative results don't get published. So I think it's variable. It might help, but it's not a panacea.
What is life expectancy with AHC as they get older is what the question was.
I think we don't have enough long-term follow-up to know that for sure. I think that the E815K mutation and the severity of that particular phenotype is an issue potentially because those kids, as they get older, are less apparent. They're harder to find for longitudinal follow-up. More of them have gotten institutionalized and had secondary things, but we lose them to follow up, and then we don't necessarily know. But I don't know, Kenneth, do you have any comment about that?
Yeah, I think we looked at, when we looked at the database, I believe it was the AHC Foundation database of 173 patients. And I think there were 3 deaths in 100 patients over 10 years. Mm-hmm. So that would my calculation like put a mortality rate of 0.3% per year. So it's not very much, but over several decades, it adds up. And certainly, there's patients living to 50s and 60s. So I would say the majority, 90% of patients with HC, we can expect a long life. But certainly there is greater risk of premature death.
My adult daughter has many AHC dystonia episodes and full body dystonia episodes. She has had breakthrough partial complex seizure or focal seizures occurring. An MRI done showed damage to frontal lobe. Is this because of the seizures or AHC full-blown dystonia? Or is it just a progression from AHC itself?
Yeah, I think we discussed that in the three questions ago, right?
Okay.
I mean, I don't know if there's
Probably not.
any additional.
Yeah, I mean, honestly, frontal lobe atrophy in particular has not been really reported. I think, but you have to keep in mind that most patients, as they get older, do not have follow-up imaging. So because if there's not a reason to do imaging and it's considered a risk to put them to sleep and they're intellectually disabled and they get frightened by the machine and all this, it just doesn't get done very much. Of patients over 30 who have gotten imaging, I'm not aware of any that are normal, completely normal. But I was hoping, we sent some of our patients to the study that was Alison Bashir's study, and I'm hoping that we'll get some follow-up eventually on older patients who were referred to that study, because they did some neuropsych follow-up in conjunction with MRI neuroimaging data, and I'm hoping that we'll get some good data from that.
Yeah, and I would just add that one thing we find is when you have a local person do a brain MRI and you get a report, and then the neurologist looks at it, or someone who has some extra expertise, they may actually disagree with what the finding is. Well, it's hard to know exactly, but that's another plea for having MRI actual data being a central place to be looked at and reviewed by a group of people to make whether there's trends. But very often we disagree with the radiologist who knows nothing about AHC and may be used to different patients with dementia who have frontal lobe and they're biased. So hard to admit it, but radiologists are often wrong, and neurologists always review our own scans to get an opinion. So just what I'm saying is, don't take the report as gospel. You may need to have a person review it, and if you're going to see an AHC person, bring the MRI on a disc with you so they can look at the data itself and not rely on the report.
It's a good.
Yeah.
Why does the AHC episodes / seizures change in manifestation, duration, recovery time, severity, symptoms, etc.?
I can't comment on that in totality, but what I will tell you is that my thoughts of why they evolve over time has to do, again, with maturation of the nervous system and different things that are happening in development. For instance, when babies are first born, they still don't have full myelination in the brain. And even babies, neonates with seizures, have different manifestations for seizures, and sometimes they're harder to recognize than in older children who are all connected by their myelin later. And so that's one aspect. I think also there is some loss of critical cells over time. And I think that the appearance later in life of the shuffling gait and some degree of Parkinsonism traits that we see, where they have head flexion and flexion at the waist when they're walking, a little bit more ataxic gait, and some of the other slowness of speech and dysarthria and things. I think those evolve because they've lost some, there's been some probable cell death over time related to this disorder, the stress of this disorder. But again, that's very hard to say. That's purely a hypothesis at this point.
Do your AHC kiddos have problems with gas buildup? Any idea for how to combat it or what is causing it?
Well, every neurologic patient, you know, has an increased risk for their gut not working normally. And I think that that's true of these patients. Their autonomic nervous system is not normal. And I think that there are times the reason gas builds up is because their gut might not be emptying as regularly as it should. And, you know, or they could be gasping in extra air. It could be if they have a G tube that there's not venting. So I think that that's something that a GI doc can be very helpful in sort of, you know, reviewing everything and trying to figure out what the root cause is and are the things that you can do. Activity levels matter to make the bowels move. So if they're not up walking around and running around as much as a normal kid, you can get constipation and gas buildup. So those are all factors.
Yeah, just keep in mind that motility of the gut is controlled by local neurons in the gut that contract the muscle to move things along. And it's a neuron, so it expresses the same genes in ATP1A3 probably as in the brain. I think that's been shown, at least in some animal models. So it's probably related to disease, I would think, too.
Yeah, and it's common in AHC to have gastrointestinal disorders. The Duke group did publish, I think, about a year ago on GI manifestations of AHC. And it was very common to have all kinds of different GI symptomology.
For sure.
For AHC kids and adults with OCD behaviors, does it get worse as they get older? And if so, what medication or treatment is given for that?
We need our neuropsychologist here. I don't know if they get worse with age. It's very common in our patient population to develop, to really get fixed on an idea or a behavior and to get stuck. And they're very concrete. They don't, it's hard to redirect them. So I think that there's a lot of different strategies that you can use that don't involve medication. One of the most common groups of medicines that are used are the serotonin reuptake inhibitors and other drugs, but it's often a very frustrating problem. And behavioral therapy, I think, has a huge role in management.
Why the mood changes in behavior? Is it due to AHC condition, episodes, medications, weather, or stressful events in their surroundings that alter their behavior, or wanting to control their caretakers as they want their parents, either one, to take care of them only? Is this a manipulation to control caregivers, especially mothers and fathers? Sorry.
I think that it probably, after they listened to Alice Belgrade, they probably got a lot of insight into that. I think I think the reinforcement, of course, they don't purposely choose to have bad behaviors, but in someone who has a lot of challenges and frustrations, and probably lack of impulse control, I think that that's all a manifestation of the underlying impact of this disease on the brain. But how we respond to it has a huge impact on how out of control it gets, and what medications to use are really, that's very individualized depending on what's going on with the child. or the adult in question.
AHC females during menstrual cycle and hormone changes. It's a big trigger for the episodes and seizures. If so, what medication or treatment are helpful during this time?
Kevin, do you have any ideas?
Not really, sorry.
I mean, it's really challenging. I think that there have been some patients who have been helped by going on hormone therapy, but I think that's been very poorly. It's been hard to study well, and it's not been studied specifically. And it's common with other epileptic disorders to have, epilepsy change with cycles as well as, but I think dystonia can do the same thing. They can get really bad dystonia exacerbation when they're about to start their menses. And I don't really know what the explanation for that is.
Yeah, I mean, we do it though. So we often will at least think about prescribing some sort of hormonal therapy. Just be aware if people are thinking about that those medications, hormones can really interact with a lot of other medications. So you can lose or have problems because of it. So you need to have someone who's comfortable with the hormonal side as well as the other medications. It usually involves a collaboration between a neurologist and either a gynecologist and or someone who just does that more routinely than we do. But it can be a problem if you just start something like that. Like seizure drugs, for example, can go very low and you can have a lot of unanticipated consequences, which could be bad.
Yeah, that's true.
What are the precursors to SUDEP?
Precursors or risk factors?
Risk factors, if you look at a history, I guess.
So uncontrolled epilepsy, for sure. Convulsive seizures versus non-convulsive seizures, for sure. And it seems to be something, it's more prevalent if you just do it per patient year in older patients than younger patients. I've had, I think, 2 patients in my career I've seen who have it, but again, this is a pediatric group, but it's definitely something that's out there. And it's one of the reasons we think we should treat for seizures with anti-seizure medicines, is we think it helps decrease the risk. But those are the main ones: uncontrolled epilepsy and generalized tonic-clonic. It's debated about the mechanism of SUDEP, whether, if people don't know it, that's sudden unexplained death in epilepsy. Patients are just found dead. And it can be due to a sort of seizure, but it can also currently is considered maybe a cardiac manifestation as well. But it's hotly studied and debated, but yeah, those are the main risks people should know about.
Yeah, I think skipping medications, anticonvulsant medications, and some say lying face down rather than on your back. And AC, I think in this circumstance, it's a precursor to CDEP. Obviously, my mom asked the question.
What are the pros and cons of phenobarbital?
Pro, it's been around since the 1920s. Cons, it's been around since the 1920s. There's a literature that it can kill brain cells, but those studies were done pretty poorly, and probably every seizure medicine and seizure type can kill brain cells. And so it's interesting, phenobarbital, at least in the pediatric epilepsy world, kind of fell out of favor, and now it's falling back in because some actual data for neonatal seizures showed it was actually better than newer drugs. So I think the jury is still out, but it's going to have more side effects typically than newer medications. It's rarely in my practice, unless you're a neonate with seizures, you're not going to get it unless you failed 5, 6 other medications and someone has a particular condition. So more negatives than positives, but I wouldn't say never use it. It's just has a long, literally 100-year now history, and but it used to be thought even worse than it is right now. So again, there's a role for it, but every drug has side effects. Every drug causes problems. But if I had to take a choice of a drug for myself or a family member, I would not choose phenobarbital.
I agree with all what Kevin said.
Yeah, I think the one pro that I think just for families to understand why it gets used so commonly in the newborn period is because of these new hypothermia protocols. There's this idea that it helps slow the metabolism a little bit and maybe is protective, right? And then there's this other issue that's not clear, but there's this other issue about its long half-life. Makes it a little bit easier to manage. I find that not necessarily true, but it's less likely to dip drastically all of a sudden. Like it, once you get it up to a steady state level, that was the theory that I was told that from the neonatologist, that it's easier to maintain a more stable level. I don't know, Kevin, do you have any comments about that?
It does have a long half-life, but the numbers will go up and down. You check every day a little bit, so. Anyway, yeah, I'd be curious of the person who asked the question about, and I think there's a particular specific thing here that they're working towards, and I think all of us would probably be happy offline to get a little more information and discuss it.
Yeah, I think it has to do with a patient that I'm aware of who they won't take it off, even though the kid's now way older than we normally would, because there might be some chance it's still helping and the other seizures are not well controlled, and this is how these patients get on so many medicines.
Exactly, but life is.
And so now being on 4 approaching 5 medicines, they're afraid to take it away. So
yeah, but life is risk benefit, and it sounds like the question is the risk more than the perceived benefit? The only way sometimes is by slowly going down, and
exactly.
Go, and that's pretty standard.
Recent research on polymicropyria by Richard Smith at Boston Children's Hospital made a lot of headlines this month. One of their findings was that ATP1A3 mutations may disrupt the balance of excitation and inhibition in the brain, which could contribute to epilepsy in other ATP1A3 related conditions.
What's the question?
I have no idea. Just read it.
Yeah, the question is, does this research contribute anything new to our understanding of AHC, or does it confirm research already known? I'll let you guys handle that one. Yeah, it's just interesting how this, it's a critical a gene, the ATP1A3, we need it for our survival. And we were so surprised earlier on to find, this gene causes RDP and causes CAPOS and causes FIPWE and causes so many other manifestations. And now it's found to be responsible for polymicrogyria, which is an abnormal formation in the surface cortical regions of the brain developing in the mid-trimester of pregnancy. So it's not totally surprising that we're seeing such a wide manifestations of neurological syndromes with this very critical for life gene. So, but it's quite interesting how more and more of these syndromes will be identified. I guess the big question is, are these connections, if you have disorganized layering of neurons where you see in polymicrogyria, is this disrupt the communication, horizontal and vertical transmission between nerve cells? Is that help us in understanding some of the manifestations of AHC. So I'm readdressing the question. I'm not giving an answer. I'll let you guys give the
No.
answer.
So I thought just comment about the work. So just in the context of how this was like, how this contributes to the literature. So one of the things that we haven't had tools to do is during fetal development, at different points during fetal development, to understand all the different things that are happening, exactly what Dr. Silver just said. And we know that prenatally, there's all sorts of different, this is such a critical gene in neurons that, it's not surprising that it's there. And so this is just to give, it just gives us more insight about its importance and where it is in cells in the brain in the fetus and so on. But it's really meant as more of a mapping. It's really trying to understand what's happening during development, as opposed to, it's not a primary focus on ATP1A3 in particular. I mean, it is, because they're looking at that transcriptome. But they're making a whole fetal atlas of all the different genes and the transcripts that contribute during development to better understand development. And so all of the different genes that are important in neurons are going to show up in this map. But this tells us a little bit more about where they're important, what regions of the brain, when the highest levels of expression of ATP1A3 are happening, and that sort of thing. And then what might, if it was disrupted at a critical time point, what might happen to the brain, right? Like it's quite, like, I don't know how much it helps us in terms of specific mutations in ATP1A3. This is just looking at the normal gene expression and its role in development in cells, not specifically with different mutations in the gene. That could be something that comes out of this, though. Now that we're starting to get some data on this, at the end of the day, that will be important, because maybe we'll find out that ATP1A3 expression, and this is true in other neurodevelopmental disorders, that the most critical time is during the third trimester or the first trimester or whatever, and maybe certain mutations in the gene impact that function so severely that they're going to have developmental brain abnormality and others aren't, or maybe there are other factors that go into that. But I will say that in one of our early autopsies, and many people have thought of HC as a neurodevelopmental disorder because it starts from the neonatal period with symptoms. So it's not surprising that something is happening with those cells, or that not all the cells might go to the right place, since we know it impacts kids so early. I don't know if that really answers the question, but I mean, I think it's helpful. All knowledge is helpful, but it's not specifically contributing to understanding the mutations in HP, but the importance of the gene itself in brain development overall.
Okay,
And
last question.
that lab is spectacular, by the way. I'm very excited they're paying attention to ATP1A3. They also have that team also has a zebrafish model that I think that would be very useful for further studies of mutations in HP. Not this group exactly, but a sister group at the Boston Children's.
Okay, this is the last question that we have. It's very long, so sorry if I bumble. Multi-institution collaboration, co-led at Boston Children's Hospital, were among researchers who first discovered the association between 16p11.2 and autism spectrum disorder. The recent study demonstrated that the RHOA pathway plays an important role in the development of a network hyperactivity in these cells, and that inhibiting this pathway may be a potential new way to treat diseases like autism and neuropsychiatric disorders linked to 16p11.2 and copy number variations. Does this research translate to AHC, which is on the 19th chromosome instead of the 16th?
So do you want the short answer or the long answer?
Short first, please. No.
No.
I'm kidding.
The long answer is, again, this is knowledge. How does the brain develop? How do aberrations cause neuropsychiatric issues? What can we learn from it? The Rho kinase, they talked about RHO, that's one player. There's literally thousands of different genes and proteins expressed in the brain that interact. And we are finding, if you compare different developmental diseases, they have more commonalities in terms of either the mechanisms or the genes or the pathways. And it's a really, really hot area of research. So while I don't think on the surface there's a direct connection between this pathway for autism with the chromosome 16 big change versus the ATP1A3 pathway, we don't know enough to see whether they connect or not. So again, it's a part of the puzzle. Human brains are obviously complicated, and maybe someday we'll find you can connect the dots 3 steps down. But right now, to me, there's no easy insider connection. But people are working on every disease, every gene, every chromosome. And again, as Kathy just said a few minutes ago, it's all new information. It's all helpful. But I don't have an easy aha moment to go from this discovery to what we've been talking about here.
Anyone else? Okay, we can start going through some of the chat questions. We've got some time left here. I know we touched on CBD oil briefly, but this person would like to know, in your practice with the kids that you've seen with AHC, what is your view on the efficacy of CBD oil on AHC?
I'd say it's a mixed bag again. It's like flunarizine to me. Some families report good efficacy, but when I look at what they're giving their child, the dosing is all over the place. When they ask my advice, and whether it's my patients or just email exchanges that I've done with some people on this call, actually, I give them best information for dosing based on the epilepsy world, because that's the best data we have. Again, at least trying to be consistent. And I think the bottom line is we don't know. But I have years of experience now with cannabinoids in epilepsy, and I think in general, it's pretty well tolerated. I prescribe much nastier things at different times to patients versus CBD. But when I started this, I didn't know. But it seems like in that context, kind of risk benefit, the benefit is potential and the risk to me doesn't seem too bad, other than the usual caveats that it's a medicine, it can interact with other drugs, side effects can be expensive, but I think it's a reasonable thing. Again, I have no idea how cannabinoid connects from a cellular pathway to do something good in AHC, but that's never stopped us before from going forward. And I've been an advocate for a while, and people know we've talked about this, of having a decent clinical trial done to answer this question better, as opposed to what is happening already, which is not good, which is everyone just doing it and trying it. And then people have firm ideas, opinions, but whether it works or not. That was a disservice, I think, to the field, because then we'll just have more maybe kind of stuff. We want to have good data. I don't think it'd be too hard to get some good data out of this. We've actually got approval from the company that makes Epidiolex. I just checked with them last week because they got bought out by another drug company because they're a bonanza. So GW, Greenwich, people who know this stuff are now Jazz Pharmaceuticals, or they're going to become Jazz. And they were sold for billions of dollars because they want their product. But they told me they're still committed to providing us with drug and placebo to do a trial. So chalk it up to COVID. Obviously, things didn't happen, but I want to move forward with it. And I hope people are supportive and can do something. But my hope is they're going to get at least some rigorous data to answer this question. But my bottom line is I wouldn't do the trial if I thought it was a bad drug. They had a lot of side effects. And I don't think that's the case, at least. So that's where we're at with it. I knew that was going to come up. So I just want to give people a little more background that 2021, 2022, I want to push forward with making this a reality.
That's very exciting, actually. So I have not used it a lot. I've had a handful of patients who've done it, but where I think the benefit has been is a bias by the type of patients I see, which are a little bit older. I think it's had potentially benefit on anxiety. So the question is what trial to do? Like, do you use it as an adjunct for, like, do you count episodes and hope that it works there? Do you think like it would be valuable to look at its impact on behavior and mood, because that's a huge issue on our older patient population? And I think, I don't know the answer to that. I'm very supportive of controlled trials, though. They absolutely need to be done, and we have to power them properly, and we have to get some answers.
Yeah, and that's why it was key that the company also agreed to provide the matched placebo, so we can do it right. Because this is this oily stuff that we talked about the G-tube an hour ago. This is a different version of it, but if you think you're getting it and it smells and looks like it, you're going to have certain biases as a family member as well as a doctor. But if none of us know what's going on really until we crack the code, we'll get the best possible data. So they're going to provide both the matched placebo as well as the active drug. And the way I was thinking trials should go, and I want to get too in the weeds for this call, I want everyone to have the chance to be on the drug, but we have to have a control group at some point so we can measure episodes. And then, Kathy, to your really important point, in the epilepsy world too, anxiety is the most commonly appreciated beneficial thing as well. So that will probably be a secondary outcome, I would think, is your quality of life and anxiety score. But the primary would probably have to be like hemiplegia and dystonia. And I'm trying to do both cheap and high quality. And then my brother is an aeronautical engineer. He used to work for NASA. And if you guys follow space things, they have a saying there, which is true for us too. You can have it fast, cheap, or good. Pick two. And that's how that's really the guiding principle for doing rocket flight.
I think it would be good to have a design where they have a high enough frequency of events where we can really have visualize an impact. But there is such heterogeneity to the population; it's going to be tricky. The control versus and this is going to be a recurrent theme that we're going to have with clinical trials, which is going to be a challenge.
Yeah, but I was
100% supportive.
Yeah, I was encouraged by the sodium butyrate trial, which shows you can do in a rare disease a good piece of data. So anyway, so stay tuned, but it is still alive, and COVID will not stop us from doing it. It may have slowed us down though. So
Okay, speaking of COVID, what are your thoughts on the COVID vaccine for AHC kids?
My general guidelines, if you're 12 and up, you should get it. I think the neurological issues in COVID are real. I have not seen internationally patients with neurologic issues have any really worse effects getting the natural disease or the vaccine. I'm on a CDC panel to review vaccine side effects, and it's generally not too much in the brain. I mean, there's whole questions about brain fog, and I don't know what that means with the disease, but in the vaccine, I think it's actually very well tolerated. So I advocate fairly strongly that if you're eligible for it, and then the FDA will go lower and lower in the United States for the age of approval in the next few months, but currently it's 12 and up. I think you strongly should get it. I think it's an important public health issue. And then there is cardiac manifestations, by the way, of COVID-19. So keep that in mind. We're talking about AHC that has cardiac risk factors, I think, but I don't have any data to support that. But anyway, I'm a strong proponent of the vaccine.
Yeah, I think I am also. I think especially for our young adults, we do have a group of young adults in particular that are somewhat overweight because they can't be as active. They have exercise intolerance. That's a risk factor. The heart issue. Sometimes there's scoliosis. There could be increased chance of really getting into serious trouble with breathing. So, I'm an advocate for sure.
Yeah, and so am I. I mean, I recommend anybody over 12 to get vaccinated, I think the potential risk from the vaccine is minimized compared to the risk of getting the infection. And I think there was a study probably about a year ago that showed that people with developmental disabilities were at probably the highest risk for sustaining serious illness from COVID-19. So I think the vaccine is a lifesaver for everybody.
Yeah. I don't know about that study, but from our experience here and going through the last year, is people who have comorbid health issues involve their lungs or their immune system are the ones, at least in our hospital, who are dying adults now. So it's really the transplant population, the immunocompromised, people with respiratory lung issues. So fortunately, I think most COVID-19 from a neuro is not an issue, but the patient population you suggested is probably also at risk for respiratory issues as well, and just lack of movement, usual comorbidities. Again, I think we're all very unified to answer the question that yes, you should get it.
A follow-up question. You mentioned cardiac manifestations. This parent wants to know if there's anything important things that they should be aware of if their child does contract COVID. What should they be aware of?
Yeah, I was referring to the fact that there's been cardiomyopathy and cardiomyocarditis with COVID-19 infections. And then since we think there's a question about some arrhythmia type issues in the heart with AHC, it's just an additional concern. So if your child had COVID-19, I'd obviously want to get checked out. And then one of the things is more guidelines for athletes is that have to be really careful returning to full activity after you had COVID-19. I had COVID in October last year. I did not follow that advice at all. I won't tell you how much I ran on my treadmill at home, but my wife thought I was loony for testing the waters. But just I think you have to be careful, and I would want someone to get medically cleared. And if you're an athlete, they're doing echocardiograms, for example, for those patients, and they're finding some single-digit percentage of those patients do have cardiac issues. And you can read stories about people online where they're not allowed to compete or anything for like 4 to 6 months. So it's ruined some college careers for people, but we don't know what it means to have this cardiac involvement from this virus, but you definitely see it. But if you're doing well, otherwise seem fine, and you get a reasonable evaluation by someone who knows you medically, then it's probably gonna be okay, but I wouldn't blow it off for sure. So shortness of breath, symptoms, any sort of exercise intolerance, just general malaise, things like that would to me red flags that you should get things looked at. But I can't say I've seen any patients with AHC who have any problems with COVID-19. I haven't heard anything about that. So.
Okay. This next question is interesting. I'm not sure you're gonna be able to answer. Jackie Williamson wants to know, are we still at 1 in a million for diagnosis? It seems more and more are being diagnosed.
It's a good question. There's definitely many more diseases now known with these genes. So I think the numbers of ATP-related disorders for sure will be more common. But I was suspicious about the 1 in a million, right? Come on, that seems like such a guess number. But I think as we move forward, and maybe the meeting, if this happens in the fall in Sweden for ATP1A3, someone will have a little more epidemiology. But I think it is, yes, the answer is, I think is yes, but I don't know whether it's 1 in 900,000 or 1 in whatever, but it's still gonna be a rare disease.
Okay, the next question, thank you. It seems like preventive meds used and rescue meds are all over the place. Are there ones that tend to work more often for most, or is everything really that individualized, or just the result of our limited treatment knowledge of AHC? Is enough known to have a standard list of medications to try, especially starting the young, newly diagnosed children? That's a tough one.
I think in terms of preventive or rescue meds, those are two different. So there's prophylactic meds that we hope to reduce the frequency and severity over all of episodes. That would be some, like how people are using flunarizine. That would be a medication that you go on every day. Likewise, a preventive medication for recurrent seizures and epilepsy would be medications that you take every day. Rescue meds, I mean, I don't think those are as all over the place as people think. I mean, the large majority of the rescue meds are the benzodiazepines, a version of Versed or Ativan, or, you know, also known as lorazepam, rectal diastat or Valium. Then there are medications that induce sleep, you know, and things like that. So I in terms of a standard list of meds to try for HC, there's no proven med that actually works as a preventive medication that's ever been proven, really, right? Like, so we don't have one. We have things that we'd like to try, like we'd like to prove, like flunarizine, we think is a good preventive med in some. And the rescue meds do work to rescue both HC spells and HC epileptic spells. But I think in terms of a standard list of meds, you know, for epilepsy, that's going to depend on how the patient's presenting, their age, what formulation of drug you use. You know, there's different kinds of seizures that you can see in HC. So, you know, I think the standard list of medications are that we know actually do something for sure are very limited and restricted to the rescue medications at this point. That would be my biased point of view. But there are plenty of effective epilepsy drugs because many of the patients have relatively infrequent epileptic events. So we don't want to be too discouraging, because there are a number of well-known epilepsy drugs that really often work so that to prevent most episodes of recurrent epilepsy in a lot of these kids. Don't you think, Kevin? So I think you have to sort of look at the broad picture.
Yeah, I agree. We have much better tools and knowledge about the epilepsy part of it than we do the non-epilepsy parts.
The next question, since the study was done, is there anyone still taking sodium oxybate as a rescue med? Why or why not? Would you recommend it?
So I know of only one.
And I think I'm on the call, actually.
Well,
hi guys.
Two. I say there's two actually then, because there's another patient on the call that are still taking it.
Yeah. Hi, Dr. Swoboda.
Hello.
Yeah. Tom O'Brien here from Ireland. We may have mentioned it yesterday. We participated in Dr. Swoboda's study some years back with Kate when she was much younger. We still use sodium oxybate. Now we only use a 2 ml dose, which is still, I think, probably a dose we started on we were on years ago. So we haven't gone up on that dose. It still seems to have it still seems to take the edge off, and sometimes either brings her out of a dystonic thought episode or helps her rest or relax, or doesn't bring her to sleep as much as it used to, because obviously she's gotten much bigger. She's 12 years of age now. But yeah, I mean, we like it because we can give it to her and it'll take the edge off over that half hour to an hour where she might come back, and she'd be, you know, as right as rain. Then she's, you know, if it doesn't seem to leave her drowsy, so she could have a dose in the early afternoon, and for the rest of the evening she could be okay. That's just our experience, obviously. One question I have actually for Dr. Swoboda is that you mentioned earlier that some kids who'd been on sodium oxybate had experienced sleep apnea. I mean, we've sent Caitlin for a sleep test, apnea test, and that she obviously hadn't sodium oxybate in her system on the night, and she seems to be fine in that regard. But given the facts I've just given you there, would there be any reason for us to cease giving her the SO or continue using it if it's working for us?
So I think the other person who's on the call has a daughter on it. We used it for rescue, and she's still using it, I think, for rescue of quadriplegic episodes. I would say 3 of the 6 children had a really impressive result in rescue with sodium oxybate. And sodium oxybate works by, if you use it in the dose that we're supposed to for children for narcolepsy, you give like 9 grams of the stuff. It's a huge amount. And you immediately push them into deep sleep. And during that process, the Purkinje cells, it hyperpolarizes them. And so they can't depolarize so easily. And I think that's why it works to rescue episodes. So the way we did our study with sodium oxybate, which I purposely ended up deciding not to publish because the company decided not to take it forward. And I didn't want to prevent the use of it in the future because I think it needs to be studied. We used it in a much smaller dose, I think 20 milligram per kilogram as a rescue during the day when they had spells. And I studied all of the kids overnight as well with EEG, if you recall, and she did not have the sleep apnea with the dose that we gave her at that time. So, or I wouldn't have kept her on it.
Yeah.
But we had one child that had a near-death event in a car seat during the study, and that's what terrified everyone. And we don't have any idea whether that child would have had an apneic episode in the car seat anyway. Could well have, because that child had pretty severe disease and was known to do that. And I specifically selected kids, though, that didn't have epilepsy or known epilepsy at the onset of the study. Because there's some theoretical risk if you use a high enough dose of sodium oxybate, you could lower seizure threshold. But I think it's very impressive alternative to rescue. And there's a new version. So one of the problems with sodium oxybate is they add a huge amount of sodium to it, which we also weren't sure how that would affect the pathophysiology of the drug. There's now been, actually Jazz Pharmaceuticals used to have it. I'm not sure if they still have it. But there's a new version without as much sodium that would definitely be a candidate for rescue because it rapidly induces sleep and sleep aborts these episodes and it works really well. And I don't know if the other parent who's on here who I know whose child is still, we used it a couple of years ago at a meeting to rescue her, during the meeting when she was having her quadriplegic episodes. But I still think the theory is a strong one that it works on Purkinje, cerebellar Purkinje cells to hyperpolarize them. And I think there's more reason for this drug to be used effectively for rescue than almost any other drug.
Well, we've been using it for 10 years now, and I can tell you guys we'd be lost without it. So that's
okay.
Yeah.
Thank you for that. Dr. Swoboda, we only have a couple minutes left. 2 quick questions.
Yes.
In your experience for the panel, have you seen many kids with scoliosis that have AHC?
Yes, the kids who are profoundly hypotonic and ataxia and never walk, almost all of them get scoliosis as they grow during childhood and into puberty. And it can influence, it can cause, in severe cases, if it's not effectively treated or managed, it can cause compression of one lung if the scoliosis gets severe enough. And so it needs to be managed proactively, for sure. But in general, kids who have been able to walk at some point, for the most part, if they get scoliosis, it's been relatively modest, and often occurs during their pubertal growth spurt in that case.
The last question is, my daughter has been clinically diagnosed. Should we go, this was years ago, she's 32 years old now. Should we go back and have the next level of genetics testing done to see if we can find the mutation that wasn't identified the first time?
Yes, absolutely. Technology continues to get better.
Always.
Yes. Because in fact, we have, there was a question we didn't answer that was in the chat. I saw it early on about how many don't have mutations in ATP1A3 who have AHC. We do have patients with SCN1A that look like AHC. We have patients with CAC and A1A that mimic HC. We have a patient with the GRIN2B that's mentioned. We have another couple of different mutations, CNCK, I can't remember the full name of that gene. So there are mimics of this syndrome that really overlap a lot and probably have shared common pathways to some degree, but all of the genetic techniques that we used back then have been improved upon, because we originally screened our whole database with whole genome at a time when it wasn't really developed enough Then we went back with McCarty's group. They did the trios. That's how the gene was found. And then we went back and did exome sequencing of individual exons throughout the gene. But that can easily miss intronic variants or other variants outside of the critical region, that some of those cases that were screened negative, even if they were screened at that time back in 2012, they should be looked at again. Absolutely, with new technologies.
Thank you, doctors. I think we're out of time.
Okay, perfect.